like £78 million has gone on that. So 63 million pounds effectively just to stand still. But we've also chosen to invest on things like safe staffing for our wards, safe staffing levels in our social care services, and to look at improving the compliance levels of some of our core elements of service like health and safety, information governance, contractual compliance, all the things that you need to have as to run safe, sustainable, high quality health and social care services for the island. So just running through the last 12 months, we were given an operating budget of £346 million, just over. We have overspent in the last 12 months, and I think you will have seen that reported. That is a significantly lower level of overspend than what we had the previous year. And we had committed later in the year, around Christmas time, with the DHSC, that we would not overspend by anything more than £15.8 million, and we have achieved that. We are absolutely ambitious about reducing the level of overspend and delivering services within the budget, but equally we have to marry that against the demands on health services and the increasing cost of health services. I'm really proud that we have been able to deliver £11.7 million of cost improvement savings. So these are savings where we have been able to demonstrate a benefit to frontline services whilst also reducing the cost and having that focus on productivity and efficiency. Things like medicines optimisation are often those areas where we know we can make a positive difference to those using our services whilst also saving costs on drugs. So just to explain that graph on the left-hand side a little bit more, that essentially shows where our money has gone and ultimately what that level of overspend is. So you can see that just in terms of the pay awards for the financial year 24-25, our pay awards have cost us almost £11 million. It's a huge amount of money, isn't it? So we have spent £11 million on pay awards. We also know that the cost of off-island health and care has cost us £5 million more than the budget that we had. And that's why that is such a strong area of focus about looking at into 25-26, how we can look at services to come back to the island and get stronger contractual relationships with those services in the northwest in order to be assured that patients who do go off the island for care definitely do need to do that. And if possible, can we deliver those services here? And we can talk more about that in the Q&A. So ultimately, I think we go into the next year with a high degree of confidence that we have worked really closely with the Department of Health and Social Care to ensure that we have stronger alignment between the mandate and our operating plan, that we understand the costs of our services, and that we are, where possible, driving out the efficiency of our services whilst doing our utmost to protect frontline delivery and care. So I get the horrible job of starting off on the finance, but now colleagues will talk through some of the really positive achievements and also some of the challenges in some of the services that we deliver. And I think I'm going to Tim next to talk us through mental health and social care. Thank you.
Thanks very much, Teresa. Good evening, everybody. Oh, it's actually the light shining, so I'll come this side. So thank you for sparing a few minutes of your time just to listen to each of us talk about our successes and challenges in the first year, in the last financial year. I've been here just on a year now, just over a year. So it's a really good opportunity for me to just reflect on the progress that we've made in a number of areas, but also just highlight the challenges we've got for the medium term here on the island. And we're an integrated social care, mental health, safeguarding and our primary community service. So what I've done is mixed up our different challenges and achievements, so it's not kind of structured in any particular way, but I will kind of reflect on that as I go along. The first point is around, we take domestic abuse incredibly seriously, and we've invested some time in ensuring that we've got a colleague who can support young people who are affected by domestic violence right across Manx care, and that's something we want to continue and build upon as we move forward. Part of my role is around ensuring that social work is treated with equity across the island, and we promote the amazing work that social workers are doing right across the island. And we're both taking forward a new social work academy model. That's about growing our own effectively, but also training and developing our social workers to be world class, but also a successful World Social Work Day, which we've held for the second time, certainly since I've been here, very successfully earlier on this year. We achieved a very positive, extremely positive, we're probably slightly underplaying it, fostering adoption inspection report, which is available on the website. We're incredibly proud of that. Huge amount of hard work's gone into that. When I arrived, we were struggling to recruit foster carers, struggling to ensure they were supported effectively, and we've done a huge amount of work. We're working really closely with registrations and inspections to ensure that we achieve a really good outcome and continue that improvement cycle in that area. So we're very proud of that, and it's testimony to the work the team have done in that space. We were nominated for a Children and People Now award. For those of you who don't know, Children and People Now is a big thing in children's social care services in particular, and we were nominated for an award at both Manx Care and St Christopher's, who we commissioned to deliver residential care services for children on the island, recognised for the great work they're doing in that space and working really closely with the charity in that area. We opened some in Hillview. I'm sure most of you will have spotted that. Delighted that it opened on time and in budget. Testimony to the work we did right across the island, working with the government and other partners, not just within Manx Care, to get that delivered effectively. 45 residential care beds, 15 nursing beds, great facility for those of you who've seen it. And we're just really proud to have done that in collaboration with other partners from right across the island. And we're continuing to work with the provider to ensure that delivers good care to residents who access that facility. We've gained approval for the replacement of Ratcliffe Villas. It's a huge thank you to the Treasury for that. I know that's been running along in the background for a little bit of time now, and we've managed to get that through the door this year, and work on that is due to start later on this year, and that's a new respite facility, as you can see from the slide, and that's really, really important to us. We do struggle with capacity and quality of provision in that space, particularly from a buildings perspective. We opened a dementia-friendly lounge in Ward 6, and for those of you who are in and around the hospital, you'll be able to get experience and see that yourselves at some point. And we've also, I went to the opening at the landing court of the refreshed outdoor space for service users there, which I think is already proving hugely, hugely popular. We've developed, this is a really important one, developed a new framework for adult social work, and that's something we needed to really accelerate under my team's leadership, and that's something we've done very well this year. With things like timeliness of assessments and the way we deliver that professional work right across the island, and a new CPD programme that supports that as well for our social workers moving forward. And again, mentioning what I said at the start about achieving equity for social workers in our integrated services in Manx Care is something that's really close to our hearts. Our Drug and Alcohol team, you might know it as the DAT, received an Equality, Diversity and Inclusion Award at the Manx Care Awards in February 2025. I happen to be on their table. And I can tell you how delighted they were. They were super delighted, and quite right. They do some absolutely fantastic work, often unseen, but brilliant, brilliant work from that team, and well deserved. And equality, diversity, and inclusion is something that is more and more important to us as a leadership group and as an organisation as we move through into this financial year. Some great work around mental health. First contact practitioner, that's about being able to access mental health services at an earlier point. Again, very successful early pilot work, and we're looking to roll that out beyond what we've already done. So that's currently in Peel and Southern practices, and also the perinatal team and UCBT services, I apologise. That's really about accelerating the work we're doing in mental health to ensure that services are accessed at an earlier point than they have historically been. 89% of people seeking access to psychological treatments. Our target is 90%. So if you speak to me in a few weeks' time, we'll have gone over that threshold, I'm sure, but we're really proud of that. It's been a significant journey to achieve that. and that's about first treatment within 18 weeks, which is a significant improvement on where we were in previous years. First contact service for musculoskeletal, expanded into the community, and outpatient physio open a self-referral pathway. So this is attempting to make sure that services are easier to access, simpler to understand in terms of the navigation of where you're heading towards your particular area of service and support. And then of course our primary care dermatology service, now in each of our 4 localities, north, east, south and west, and they're developing well. I'm sure we'll talk a bit about that in the question and answer, which I'm very happy to take any questions on. And then the establishment, just on that issue finally, in terms of achievements, the establishment of our first health and care hub in the north of the island in Ramsey, and we've held our first board meeting a few weeks ago to really drive the partnership working in that space, and there's some fantastic work going on with Gary and the team in that space. In terms of challenges, I've moved to I can't actually see them in the screens, that's my fault. I want to highlight a few, I don't want to read through all of them. There's a theme around accommodation and our estate and the buildings we operate out of, both in terms of capacity and quality, and that's something we want to work really closely with our government colleagues to improve. We've made some strides this year, but we want to do a lot more, particularly around children with disabilities and our caregiving population, where we've got very close to running out of capacity this year, and we need to do better on that in future years. I also want to emphasise the culture and the shift to prevention and early intervention. I don't want to underemphasise what a big journey that is, an important journey for us to make, and that's something that runs right across Manx care. We're on that journey, we're leading that field in many areas in my portfolio, but I know we're very, very keen to do more of that, because we both achieve better outcomes for residents, but also it can be better value for money. We use our Manx power more effectively in that early intervention space. And then really linked to that, commissioning, something we're working quite hard on at the moment to do more of, do it better. So plan, do, review is the basic concept of commissioning. I think what we inherited, sometimes we are contracting but not commissioning, we're not thinking about the longer term, we're not thinking about colleagues in public health, sat at the back, looking slightly sheepish. Hi Ross. Working really closely with our public health colleagues to make sure that what we know about the island in terms of our residents and our population and what's going to happen in the longer term play into how we commission services at this point in time and moving forward. So we'll be doing quite a bit of work on that in the coming year. And then the bottom one, which I'm sure we'll talk about in the question and answer, particularly our general practice and dental capacity is something that requires turbocharging. We know that, and there's a lot of work going on in that space at the moment, but I won't talk about that in detail. I'm sure there'll be a chance to cover that during the question and answer. So those are the highlights. Thank you. Thank you very much. I've got that 5 quickly. Thank you very much indeed.
Is that all you offer?
No. Oliver, do you want to go next?
Yeah, thanks. So I said earlier, my name is Oliver Radford. I'm the Director of Health Services, so my remit encompasses primarily the hospital, but also the relationship that we have with the UK, our UK specialist providers. So got a number of achievements I want to just run through, and then only 3 challenges, but they're quite broad brushed. So in terms of our achievements, a number of these are kind of related to our services being peer reviewed by specialist organisations in the UK. We're really keen to do that across all of our services to make sure that the services that we deliver are the same standard and quality as you would expect to be delivered in the UK. So the first couple there, well the first 3 actually are peer review. So the first one is the Association of Perioperative Practice. So that's the organisation that governs and helps to regulate operating theatre practice. They undertook a peer review of our operating theatre services last year, and the outcome was that they found that our operating theatre services were excellent in terms of standards of care. The next one, which is GAMSAS, which I won't attempt to tell you what that stands for, but it's the association in the UK that looks at antimicrobial stewardship. So that's the judicious use of antibiotics both in the hospital and in the community. As we know, you may know that antibiotic resistance is one of the key risks across the world, basically antibiotic stopping being effective because of widespread and inappropriate antibiotic use. We're one of the few hospitals that was assessed last year to achieve level 2 of the accreditation for antimicrobial stewardship, which is, as I say, we're one of only few hospitals in the country to achieve that, and that's a huge achievement for our antimicrobial team, which is our consultant microbiologist, Dr. Carr, and our antimicrobial pharmacist, Matt Davey. Again, another peer review that was undertaken of our anticoagulant service, and it was also one of the best in the British Isles. We introduced last year baby loss certificates, or earlier this year rather, baby loss certificates. So that is a certificate that is issued essentially by the government registries to confirm if somebody's had a miscarriage, which is something that's been in place in the UK for some time. We also opened the Bluebell Suite, which is a room that was opened and developed within our maternity unit if somebody suffers baby loss. We opened a gynae ambulatory care unit, which was opened and developed thanks to the generosity of the Friends of Nobles, which sees women who have got gynae emergencies, including issues in early pregnancy. That is the first stage of the changes to the way that we're operating and delivering gynae services, as Sheila talked about on the radio slightly earlier. We opened the Manx Integrated Sexual Health Centre, MISH as it's known, which is located in the Old Kensington, or the Old Finch Hill GP practice. That brings together all of our sexual health services, takes some of those from the hospital, places them into community, and brings together all of our family planning services into a single building. So all of that team is now co-located and is now working together to deliver integrated sexual health services. Just going back to the peer review, we had a peer review from the Cheshire and Merseyside Critical Care and Major Trauma Networks. So these are, we are members of those networks, and again they are pivotal in making sure that the major trauma care that we offer, as well as critical care, is of the highest standards. And again, the peer review process that we went through last year received brilliant feedback. Last year we've had some real success around homegrown professionals. So we are the first midwife to be trained on the Isle of Man in conjunction with the University of Salford. Graduated and is now working clinically in our maternity unit, and also our partnership with the University of Cumbria to produce homegrown paramedics is in its final year. Wendy mentioned earlier around visiting consultants. We've been lucky enough to develop a partnership with Wrightington Hospital, which is the Greater Manchester's specialist hospital for orthopaedics, as well as Aintree Hospital, to offer 3 visiting clinics, 2 upper limb and 1 foot and ankle. Those otherwise would have required individuals to travel across to those hospitals to receive that care, which is both cost effective and better in terms of patient experience. And then finally, during the first year of our new intermediate care service, which is a new service which launched last April, which is basically a service that bridges from hospital to home, as well as providing some pathways that prevent admission. For those patients that they managed to discharge earlier than would have normally been the case, have actually reduced their length of stay from 44 days to 21 days. And people who are maybe interested in learning a bit more intermediate care, our head of service for intermediate care, Michelle, gave a really good presentation at our public board meeting earlier, which will be available to listen to shortly on our website. In terms of challenges, Tim touched on my first challenge, which is our estate. We've got some fantastic new buildings within our estate, Summerhill View being the most recent, Manannan Court also being opened in the last few years. But we've also got some really old buildings. The hospital, although it was only opened in 2003, is already showing signs of overuse, overcapacity. For example, our A&E department is around 35% of the size that we need it to be, compared when we look at the number of attendances. Also, we don't have a ward that enables us to flex up and down during times of increased demand, meaning that, particularly during the winter period, we do have increased length of stay within ED because the hospital is basically full. That's something that we're looking to develop at the moment. In addition, our equipment, so when the hospital was built, all the equipment was brought brand new, so it's all going out of date at around the same time. So we've just been successful in gaining funding from the Treasury to replace our MRI scanner, but we have multiple areas of risk around both hospital and out-of-hospital services around equipment needing replacement, and that's something that we're really going to concentrate this year with the Treasury and the DHSC colleagues to develop a comprehensive capital asset programme, because the last thing that we want is waiting times extended because of pieces of equipment going out of service. The second challenge is demand exceeding capacity across all services. Waiting lists, waiting times, access to GPs, etc. Dental waiting lists is never far from the headlines. And in a service, in a health service, like Teresa mentioned, that is financially constrained, that is really difficult to try to ensure that we improve access to services whilst remaining in financial balance. And the point of the transformation programme was to really transform services and look at how we can deliver services more effectively, more efficiently, and basically smarter. So one of the examples of that is our advice and guidance service for initially respiratory patients. So that is a service whereby GPs can contact our respiratory team for advice. So rather than the patient being referred formally to the respiratory service and maybe being seen in a few months' time, depending on the urgency of the condition, the GP inquires with our respiratory consultant team. This is a patient with these problems, what do you recommend? They get back much quicker than allocating an appointment. So that means that we can reduce the number of formal referrals coming into the hospital, and really make sure that the time that our respiratory team has got in the working week is used much more efficiently. Similarly, we have productivity and efficiency programs running across most of our services. Theatres, theatres are our most expensive resource, making sure that they are the most efficiently used. And then finally, lack of resilience across some key services. So, because we are such a small population, we are always having to tackle the problem of making sure that there's enough clinical work to make sure that our clinicians remain competent, but also making sure that our services are resilient. So one of those services which you will have seen recently is our breast service. We only have enough work for one breast radiologist, but having one breast radiologist is inherent with risk, because if that person leaves or goes off sick, we have problems with the service. And those kind of issues are replicated across all of our services. So that's something that we are tackling at the moment. I'm glad to say that we have recruited a new full-time breast radiologist, and they are starting in August, which is great news. But I think that is one service of many that we do need to look at the resilience of those services, and I think our relationship with UK providers is a really good example of where we can tap into UK specialists to provide that resilience that we need. So whether that's visiting consultants supporting our on island consultants, whether that's virtual clinics, whether that's the use of telemedicine, etc. So that's one of our key areas of focus for this year, making sure that those services that do lack resilience are improved, so that we can make sure that access to those services is maintained at all times. So that's it from me. Thank you.
Thank you. So we don't mess with the wires. No, just speak. Hello everybody, my name is Helen Ashley and I'm the Exec Director for People and Workforce. So I joined Manx on the 1st of March, so I'm still very new to the organisation, and I've been very fortunate in my first few weeks and months to be able to spend time with a large number of our colleagues in the different services across the organisation. And I think my overwhelming response and reaction to meeting those people is how fortunate we are to have such a dedicated group of professionals who look after us in Manx Care. They're a really fantastic workforce, and as a new member of the team, I'm really proud of all of the work that they do. All of my colleagues who speak this evening will inevitably talk about workforce, because all of our services are delivered by people, by colleagues, and it's impossible, I think, to overestimate the impact that people and workforce have on a service like ours. Many organisations claim in their values statements that they put people at the heart of everything that they do as an organisation. And one of the reasons that I chose to come and work here at Manx Care is that speaking to colleagues and speaking to execs as part of the recruitment process, it became clear that we really mean it in Manx Care. We're really serious about how we look after people and how we look after the people who look after the population of the island. And that's one of the things that I'm really excited about in coming to work here. You can see on the slide a bunch of achievements, and really people and workforce achievements come in 3 layers, and that's how I think of my role. So the very top layer is the individuals who deliver service, who work in the organisation. And so for me, it's important that we give those individuals the opportunity to be the best that they can be, whether that's through how we design their roles, whether it's through how we support them in terms of their professional development, whether it's in terms of how we support them as human beings who are going through good times and difficult times in their professional career. People are not always the same. We all face challenges in life, and the measure of an organisation is how we support people with those things. So that's fundamental to my practice and my work in this organisation. The layer that supports those individuals is our teams and how we work in teams, whether that's clinical teams, whether it's organisational teams. And again, what is really important is how we co-design those teams and the way that we work. So inherent in our practice as service providers and clinicians is an element of development. So practice never stands still. The way that we do things should never stand still. There's always new research, new ideas, new ways of working. And what our teams need to be able to do is implement those new ways of doing things, is to participate in the discussions. And both Tim and Oliver have already been extremely eloquent when they talk about how we're developing our services, how we're doing work in a new way. And that's all about empowering our teams and giving our experts, practitioners, the opportunity to look at how we deliver services, how we do things around here. The other element to that, in terms of developing our service, is something that sometimes is called experts by experience. And experts by experience are people who have those conditions, who live with those things, who also have a huge amount to contribute to the way that we deliver services. And one of the things that we do in People and Workforce is think about how we work with those experts, how we invite people to engage and create opportunities for people to share their ideas and their experiences. And sometimes those experiences are not great, they're not as we would wish them to be. And so the other part of that is how we learn as an organisation, and that's really the third layer that I'm interested in terms of people and workforce. And that's how we look at things holistically as an organisation. So we've already heard about some of the work that we're doing for early careers colleagues, so people who are coming out of college and university, taking their first steps on the career ladder. A lot of that work we instigate, we initiate, so we look for opportunities to bring youngsters into the workforce, bring new early career people in, and how do we support and nurture those people as they take their first steps. It's also about how do we support people through the duration of their careers. So people have career aspirations, they want to develop and grow, they become more experienced as practitioners. So when we're thinking about workforce, we need to think about how do we create the opportunities for those people as they become more experienced. And then we've got our most senior colleagues, our most experienced colleagues, who are then part of the voice of leadership in the organisation. Those are the colleagues who help us to set the organisational direction and point us towards the future in terms of the very highest standards that we aim for in this organisation. So all of those elements are pieces, are parts of the work that we do in People and Workforce. Those elements, so from the very individual level right to the macro organisational level. And I suppose one of the key things that I want to promote is that People and Workforce is for the staff. We're for the colleagues of the organisation. We're here to support, enable, and to create opportunities for those people in the organisation. And if we do all of those things successfully, then we start to address some of the challenges that we've got as an organisation. So one of the key tools that we use to understand how people in the organisation feel are our staff surveys. And we have an annual staff survey, but we also have much smaller scale elements of listening opportunities that we have throughout the organisation, throughout the year. And we're not without our challenges. We've been through a very, very difficult period as an organisation, and we need to find ways to support our organisation. Many of our colleagues have spoken about feeling out of balance, that work-life balance has not got back to where they wanted it to be before the pandemic. Part of that is making sure that our vacancies are all filled so that we've got enough colleagues to do the work that we need to do. Part of it is about making sure that our teams function successfully and that people feel like they've got a voice and they are contributing to the way that we do things around here. And part of that is making sure that our colleagues are looked after, that they're treated with respect, that they're dealing with people who understand the contribution that they make and the work that they do and treat them with civility and respect. And those, I suppose, are the key themes for People and Workforce moving forwards. So as you can tell, I get quite agitated and quite passionate about this, and I could talk something now, but I won't. I shall shush, because it's got to be someone else's turn now.
It is, and we're going to move on to the next slide, and we're going to ask Sheila to talk about the matron role and the launch of the senior matron.
Thank you. Good afternoon, everybody. When we were asked to talk about achievements, as the Executive Director of Nursing and Allied Health Professionals, today I'm going to focus on one particular role for the organisation that I believe, going forward, we must get right. having said that, I'm really proud to be the lead of our allied health professionals. So allied health professionals, just as an example, physiotherapists, dietitians, paramedics, operating department practitioners, just to name a few, speech and language. I'm really proud to be leading that area as well. And together, they are the part of that clinical leadership, including our doctors, that clinical leadership that we need in Manx care. So today I just wanted to talk to you about, you may have heard yesterday was the International Nurses Day. So big celebration, and a big celebration here in Manx care and on the island. And we're very kindly sponsored to give every nurse a small gift of appreciation for their services to Manx care. But also, we sent out thank you cards to people. And it wasn't to nurses, it was to everybody else who support nurses in their duties. I'm talking about administrative staff, people who are in what they call the back office, these professions that you've never heard of, in laboratories, etc. So it was lovely to thank them supporting nurses to do their job. I've been here about 10 months, and I've been an executive director of nursing and allied health professionals for over a decade. And when I came here, what I clearly saw was a group of nurses who were more than capable to deliver the care required. And we talk about short staffing, and a lot has been done, and Manx Care's board with the Department of Health have worked tirelessly to ensure that we do get the right safe staffing levels, and we're nearly there. Our biggest area of safe staffing at the moment is with our midwives, but we're seeing improvements in that area. But the key thing for me, what I found, is whilst our nurses are working extremely hard and they're at the forefront of working with patients both in wards and in our communities, we have to just make sure that the leadership is right and the leadership is strengthened. So yesterday, on International Nurses Day, we launched the role of the senior matron, and indeed on this afternoon I've been on the Manning line for the lunchtime show with a couple of our senior nursing leaders, senior nursing matrons, Jo from Emergency Department of Medicine, and Kathy, who supports all of our cancer care, diagnostics and Macmillan services. So the role of the matron is key, and why we bring it in is because we're not visible enough at a very senior level, and we need that visibility. And there's a top 10 that I won't go through, you could read that, but this is grounded in research around what a senior leader should look like in a clinical area. This is clinical leadership, it's not management. Nurses at this level are not managers, they're actually clinical leaders. And all I mean by that is that you need your clinical leaders to be on the floor, to be visible, to be able to role model, and also to be able to demonstrate that there is a real sound career structure for nurses in Manx Care and on this island. And if we don't provide a solid career structure where every nurse can look at what can I do next, how do I get up that ladder if I want to. If I want to stay on a ward or I want to work in the community, right by the patient bedside, that I'm able to do that, and I can develop my skills to make sure I keep up to date with what's happening for patients. And importantly, patients' carers and patients' families and the public that we serve on the Isle of Man. So just a couple of things in the dark blue boxes which I think are really, really important. So providing clear, visible and strong nursing leadership, leading by example and demonstrating to other nurses the high standards of care that patients should expect and must get. Provide a visible, accessible and authoritative presence in the clinical setting. So in order to be a senior matron, you've got to have 3 things that you must be able to do. You must have responsibility for what you do. You must be accountable and be held to account for what you do. But clearly you must have authority. And I think we've lost a little bit of that, so we're bringing that back. Giving the authority to the senior matron to act on behalf of the patients that we serve. And making sure patients get quality, taking responsibility for driving up the standards. Sometimes we get so technical we forget the basics, and that's across the world. We forget the basics, and the basics matter. You know, have you been washed? Have you been fed? Has somebody held your hand today and listened to you? Do you know what's going on next? Do you understand what's in what I call the pathway of care? Do you know what's going to happen to you from start to finish and everything in between? And making sure the wards and all the clinical areas in the community, this is not just about Nobles Hospital, we are much, much bigger than that, as we know. That areas are clean, that standards are being monitored, we are performance managing how we do things. And we're working closely with, for example, housekeeping teams and infection control teams to make sure that the patients get what they need. You rely on us, we've got the clinical capacity and capability, and we will strive to deliver better than what we're doing at the moment. Next slide, please. So, for nurses, we've got to empower them, we've got to encourage continuous quality, resolve problems for patients and their relatives. Okay, so we do something called a family-friendly test, and that's a test that's done in the UK as well as here, and the test is really just one question. Would you want your family to be looked after here? Okay, and do you know, we're over 90% on that question. But I know, as an experienced executive nurse, that we don't get it right all the time. And I know that there are certain areas where we have got it wrong. And I apologise for that. But what we must do is work with families and work with patients to get things right and make sure that those things, or we absolutely try to prevent as much as we can from those things happening again, and learning from our mistakes and being upfront, honest about that. And as part of that, that's where the senior matron comes in, freeing their time up to be able to work more closely with our patients and their families. I think there's been creep, and what happens when I say creep is that some of our nurses have probably spent too much time in front of the computer, or perhaps in meetings, that on reflection, and especially over the last 10 months, week after week, we've really worked on what we step away from, what we stop doing, in order to make sure that we get it right for everybody. We know we won't get it right every time, but when we get it wrong, that we make sure quickly and appropriately and respectfully that we support people when we have got it wrong. So, having in place high visible matrons on wards and in community areas recognises the strong nursing leadership leads to better patient care, and that when things do go wrong, there is someone there with authority, accountability and responsibility to put it right. There's lots more things I would love to talk to you about today, but from my last 10 months, this has been the most important thing to me. I rejoice that we're going out with the senior matrons. They are clinical leaders. I'm really proud of it. They're not managerial posts. We need managers, that's really, really important. They don't need to be in that space. So that's the way forward. We know that's what the public wants. We know that's what patients want, because that's what they tell us. And I'm delighted to be able to launch that yesterday. And I will come back to you to discuss the improvements with having the senior matrons on board. Thank you for your time.
Evening again. I think the last 2 slides then are for me, but really they're for Sheila and I, but I'll cover them off. So As I said earlier, I'm Chris, I'm the Executive Medical Director here. I've been here for just a little bit over 2 months now. On this first slide, I'm just going to talk you through 3 of the initiatives that we have recently strengthened here on the island that are focused around patient safety. And before I go any further, I would say that actually, if you look internationally about what the really successful healthcare systems across the world say are the best things that you could do to improve patient safety, you'll find these or examples very similar to these. This is, you know, very well tested, and I've seen it here on the island done really well. We're growing, but still really well. So the first is daily safety huddles, and this is an initiative where professionals from across the organisation come together each morning. It's only a short meeting, but everybody meets at the same time, same place, where they have a patient incident to discuss, and it could be an incident of any shape or form. And we will do a hot debrief of that situation and discuss what's happened and what do we need to do right here, right now. And that might be to stop something serious from happening. We can see something starting to brew. It might be that something has happened and we want to stop it from getting worse. It might actually just be supporting staff members who have been involved in something that's happened, who need a little bit of support to then carry on in the work that they have for the rest of the shift, for the rest of the day. But it's really important just getting different people together to be able to share what they've experienced, and also some of their ideas on how we respond most appropriately to that. The second here is Speak Up Clinics. And Speak Up Clinics are kind of like little pop-up tents. It's not really a pop-up tent, but it's kind of like a little pop-up where members of the executive team, Sheila, myself, others, will tour around and allow opportunities for staff to just come and share anything that they want to share. Absolutely confidentially. Share it. It might not be in my area, it might be a workforce issue, it might be a medical issue, it might be a nursing issue, it might be anything, but it's something that that person feels is important to share and that they want to share with us. And so we've done a number of these now. We'll continue to do them because the feedback that we're starting to get from staff is actually really helpful. Wasn't quite sure where to take that problem to, but I've brought it here, and we will make sure that it gets followed through. And importantly, that the feedback goes back to that person as well, because there's nothing worse than putting your hand up and raising an issue and then it disappearing into an abyss and you're not quite sure whether or not it's been responded to or hasn't. The last of the 3 that I've put on there is our weekly review forums. And in fact, there's been one of those this afternoon whilst we were on board. So Sheila and I weren't able to attend it, and it went on. It went on successfully, and they had a really good conversation discussing some of the more significant incidents that have occurred in recent weeks. And what happens in those is colleagues wrap around the problem. We decide actually how much more of a review needs to be done upon that problem. People come into the room to discuss different perspectives and different ways of addressing those. And we don't close any of them off until we're satisfied that everything has been drawn out from that particular incident. And one of the things I've noticed in the 2 months that I've been here is that in the early days, people were quite defensive. And health professionals inherently feel a little bit defensive. If you've been involved in something that hasn't gone quite as people had expected it to do, you naturally feel defensive. And I'd reflect upon the recent weeks' meetings when we've been there, when actually people have been really much more open in sharing problems and more open in offering constructive feedback to colleagues, which perhaps going back in time they may not have felt quite as comfortable doing. And that for me is a real sign that this is beginning to mature and that it's absolutely the right thing to do. And you see professionals from across the organisation get drawn into the meeting. They come to this meeting voluntarily. GPs, surgeons, paediatricians, nurses, physios, the ambulance team, everybody in that room having a proper grown-up conversation about how do we move that forward. Of course, that moves. Do you want to move on? That moves us then into addressing these two issues here. And the first is in terms of our complaints process. We have quite appropriately had some criticism over the times in terms of how we address complaints. Sometimes we don't address complaints in the most timely of fashions. Sometimes we answer the question that we might have liked to have been asked rather than the actual questions that were asked. And sometimes when we do answer them, we don't answer them in particularly straightforward language. And so you're left then scratching your head when you receive a response some way down the line, which has got language in it that doesn't really make a great deal of sense. And we've done a lot of work working with the Ombudsman to unpick each of those issues. So whilst there is more work to do, our complaints responses now are getting closer in terms of the time period from when that complaint was raised. We really try hard to make sure we draw out all of the concerns that you're raising in a letter, or whichever format you have raised your concern. And then we're being really careful at making sure the language that we've used going back is plain language, and that we've explained some of the technical reasons for why a particular decision was taken. We know that we have got more work to do in this space, but there's definite progress over the course of the last year, and there'll be more progress as we progress. The last point then on there is in terms of our lessons learned bulletin. I talked on the previous slide about how professionals now are drawn together to share their experiences and to talk about how they felt in a particular incident, what they might have to offer to those people that were involved in it, or ideas on how to stop that from happening. But of course that only includes the people that are in that room and the people that are having that conversation. I've learned lots of things as a doctor over a career of 20-something years that have been learning episodes that have occurred because I've got something wrong, or I've been involved in a situation that just didn't go quite in the way that people wanted it to go. Sometimes that's just bad luck, but sometimes it involves things that you would do differently next time. And that's really rich material to have. And any healthcare professional that walks past that experience is foolish indeed. We've got to share that learning with our healthcare professionals. So the lessons learned bulletin is making sure that everybody, including those people that weren't involved either in the incident or in the room discussing the incident, have the opportunity to learn from it, understand what happened, understand what opportunities there are to prevent that from happening. And it may be the discussions that we have in the Speak Up Safely conversations. It could be from our serious incident review meetings. It could be a theme coming through from concerns and complaints, or from a coroner's inquest. Don't call them coroners here, do you? You? Yes, okay. So all of those pieces of information we draw together and then share in our regular lessons bulletin. Again, more progress over the coming year, but certainly getting very good feedback from it most recently.
Thank you very much, Chris.
So that concludes the presentation part.
questions, which, as I say, thank you to those who submitted. So I'll read out the questions, and then we've got expert panel here to try and answer them as best as we can. So the first question, public perception is that whereas the budget for health has increased hugely, the services have plummeted massively at the point of contact. Even when 2% extra taxes ring-fenced specifically for health last year, elective surgeries paused for the first time I can remember. What is the biggest way you could rectify this trend? So I think that's probably one for you, Teresa.
Yeah, thank you. And I did touch on some of this in my opening remarks when I explained sort of financial context. I think it's true, we have really struggled to understand the true cost of finance, and I think moving forward we've got much closer to being able to provide detailed costings and information about what those services do indeed cost, and ultimately how we can make them slightly more cost effective moving forward. And I do think it is about having that level of honesty and transparency with everybody, you know, with the public, who we are ultimately responsible and accountable to Tynwald, to the department. It is very clear that we must modernise how we deliver some of our services. Because we do have some real challenges of, as Oliver has described, making our services sustainable for a small island. And if I can just explain that in a little bit more detail, we have to achieve the same level of quality and compliance, whether we are delivering that service for 85,000 or 850,000 or 8.5 million. Because the compliance bar is the same regardless of how many people you are providing it for, which inherently means it costs us more to try and achieve that level of compliance. But if you are having oncology services and your chemotherapy here on the island, you have every right to have it at the same standard that you would have it if you were to have it at Clatterbridge in England. But I can tell you categorically, it absolutely costs us more in order to be able to do that and achieve that here. We have to be able to explain that, and we have to provide the data. So I was looking at our data for March, and we had a baby who required 200 days on a neonatal intensive care unit across in Alderhay. £300,000. But it's really important that baby had the best care, and that's 200 days in a very, very specialist care setting, which costs money. And I think that is important information that everybody would want to know. And I don't know how I don't know that we have the answers, other than moving forward in describing what our services look like, and the DHSC I think will share this view. We have to co-produce what those services look like with those that use services, because inevitably we're going to have to change how they are designed and delivered, and there might be some difficult choices in there. But actually we have to do that with the people that use our services.
Thank you. Oliver, do you just want to add something about how we are trying to create more capacity by looking at waiting lists and looking at, you know, the intermediate care team that we heard about earlier today, and all of them on the website? But we just talk about how we create capacity to actually do more for what we've got.
Well, yes, we've identified, you know, throughout Manx Care's journey that there are areas of inefficiency across our system, whether that's theatres, whether that's extended lengths of stay in hospital, whether that's people waiting a long time for an appointment within a hospital specialty. we're importing a lot of good practice from the UK. So intermediate care, which I mentioned in my presentation, and then you just mentioned now, is a service whereby we are investing in our community services, expanding the reablement service to enable patients who are in hospital just receiving rehabilitation, to receive that rehabilitation at home. That means that individuals recover quicker, and it also frees up capacity within our hospital. It's probably worth mentioning that our demand through our emergency department is increasing by around 10% every year, and that increases the demand on our hospital. So since the hospital has opened in 2003, the demand increase in terms of beds has been around 60 beds extra. But with the initiatives that we've undertaken, things around our intermediate care being one of them, our ambulatory assessment and treatment units, which treats patients in an outpatient setting rather than admitting them, means that we can start to redress the balance of this increase in demand and basically manage things much more efficiently.
Thank you. The next question is, how is the schism between medical staff and management being improved, and why has it become so toxic? So, Chris, your new, your reflections and your thoughts on that.
So I would say that I've been here now for about 2.5 months. I don't recognise the word schism in terms of a differentiation between management and our medics here on the island. In fact, I would say the opposite. I'd say that every day I'm greeted by doctors coming to see me, not to offer objection, but to discuss the challenges that we face and what they have to contribute to helping to fix those challenges. And there are lots of ideas there. I had the privilege a few years ago of going to a talk by an American professor called Margaret Heffernan. She's on TED, if you're into TED Talks. And she talks about something called willful blindness, which is where somebody deliberately walks past something that they could improve because they don't want to put their fingerprints on it and get involved in the difficult job of bringing about the improvement. And she says that you need 3 things to bring about meaningful improvement. You need to be in the room. You need to have an active conversation. You need to be willing to put forward differences of opinion into the conversation. And then you then have to have a mature conversation, a mature debate. So I would say that I would be more concerned if we didn't have doctors who were raising different opinions to the decisions that are being made. Because healthcare faces, not just healthcare in the Isle of Man, but healthcare across the world faces some phenomenal challenges going forwards, which we've got to face and we've got to grapple with. But it's an emotive subject and it raises a lot of passion in everybody involved. So I haven't seen a schism between professionals in medicine or management. I've seen quite the contrary.
Yeah, I would say that's absolutely been my experience. We have lots of really passionate professionals in our organisation, and we disagree about things, but I see that as a really healthy element of the way that we do business in Manx Care, that people are encouraged to disagree, to share their opinion, to challenge each other, and I want us to do that more, actually. And that's been my impression since I've been here. We don't always, it's like any family, we don't always agree, we don't always see eye to eye. But I'm absolutely convinced that everybody that I've met in Manx Care wants to do their best and wants to support the population as best as they possibly can.
Thank you. So next question, how do you decide how many GP appointments are to be funded, and is there a limit? Tim?
Thank you, Chair. So there are probably 2 or 3 critical points. We know that there are pressures on our GP capacity, and we are working to address that. Critically, the funding is not aligned directly to GP appointment numbers, and that's an important point to raise. Our primary care offer is much wider than just our general practice. We're doing a fantastic job. Minor operations, monitoring chronic conditions, monitoring meds, etc., etc., etc. So, and what we're trying to do is build upon that in the short term to expand our primary care offer. A couple of examples of that: physios, mental health capacity, advanced nurse practitioners. Building that primary care offer in localities is something we're currently in the process of doing and have already done some of that. We know that the GP appointment base, if I can put it that way, has reduced slightly over the last 5 years. We know that. There's a number of reasons for that. We know that the population, I think was referred to earlier, the population is getting older, and that comorbidities and complexities are getting more complex. And GP appointment timings have increased from 10 to 15 minutes, which I think is in line with the UK. And so, and then I guess the final point is around ensuring recruitment and retention is as effective as it can possibly be on the island. So for all those reasons, this is a challenging area, but it's important to say we are absolutely focused on that in addition to what I've described in terms of the primary offer. We're piloting telephone appointments in the northern locality, in the northern hub, as I understand it, with some success, and we're looking at potentially rolling those out beyond that. And then 2 things to finish from our comments here. The first is that we absolutely welcome and we encourage feedback through, particularly through MCALS, which is our information portal, but also our friends and family survey, which I know we advertise in local practices. We want more and more of that feedback so we can work with our general practitioners and our other primary care experts to get the best offer we can possibly get within the resources we have. And we want to make, the second point is we want to make sure that communication with all of our 85,000 residents is getting better and better. We want that to improve so that we can have that conversation with you about how primary and community care works in localities, so that we make it easier to access services, and also the offer is clear and distinct to you in each of those localities. So I hope that covers it all, Chair. Thank you.
So a clinical question here. I'd like to suggest that when children come to A&E, they're not kept waiting. It is so distressing to see a child with rip-roaring temperature crying. In the meantime, there's stuff about the care there. Where is the care and compassion is the key to this question. And then there's a secondary follow-up to this question, which is the cleanliness of the hospital is something that needs addressing. So we'll start with you, Chris, and then we come to Sheila, I think, for the second question.
Okay, so children come into the emergency department. So I suppose the first thing I would say is that everybody, child or otherwise, that comes to the emergency department is triage. And we use a tool called the Manchester Triage scale, which is, I can't think of any place that doesn't use the Manchester Triage scale. And it has a different section for children from adults because it recognises that children aren't just unique adults, but that they have all sorts of other unique needs. And we do fairly well here in terms of how quickly we triage children, and then in fact how quickly we see them following triage. Where it's possible, then they wait in the children's part of the emergency department. It's not always possible to do that. If a child's got very complicated needs, then sometimes it's important that you sort of have eyes on them whilst they're waiting, and so that sometimes influences decisions. We've got a separate treatment room in the emergency department for children, and we use that wherever it's possible to do so as well. But you heard Oliver earlier explain how our emergency department footprint is much smaller than a modern emergency department might be according to current specifications. And so sometimes that room already has a child occupying it, and we have to use different rooms as a consequence. One of the other ways that we're trying to work through this is to see as many children as possible direct on the children's ward. That works really well when it's safe to do that. But I can speak from experience on how scary it is as a junior doctor on a children's ward when you're suddenly confronted with a very unwell child that you weren't expecting until they walked through the door. Because you don't have quite the same facilities around you as you might have in the emergency department. So it's not possible to see all children directly on the ward, but where possible, that's what we would do.
Thank you. And of course, we apologise for any distress when we just can't meet all those standards. If those things happen, it's really important that we recognise that. Sheila, cleanliness, and what are your matrons going to do to change that?
Yes, and just leading on from what Chris has said, so we've got a new senior matron for children, Louise Proudford. And Louise, straight away, when she arrived, was looking at exactly what Chris was describing. The facility in the emergency department is not good. We know this, it's extremely small. And that's due to, when the hospital was built 20 odd years ago, it wasn't what the modern expectation is now, where children have a whole different doorway coming into the emergency department, quite separate. We haven't got that at the moment. We're doing our best around that, but we're also looking with our Department of Health and Social Care what our emergency department might look like in the future. I find I'm also the Director for Infection Prevention and Control in the organisation, and I find particularly Nobles, because that's what we're talking about, is quite a clean hospital, but there are parts that are tired, and I think the emergency department is one, and some areas, especially around the front entrance, which we're constantly having additional housekeeping in. And I just popped into the children's section of the emergency department before I came out today. And it was clean and it was very presentable, but it was empty at the time. So I do recognise when I walk through sometimes at 8 o'clock in the evening, the ED is full, there's a few children in there. It can get quite dishevelled, and you do have some poorly children in there. It's not the best environment, but we really are doing our best with a view to we need to modernise that area for the future, to the point where we can have our children, as Chris has said, those children that absolutely have to be in the emergency department without a shadow of a doubt. They can't be down in the children's area, and they have to be in the emergency department and get that environment much improved in the future.
Yeah, and I think this is why we have seen the refurbishment and the building of a new emergency department really increase up the priority list for our capital investment, because we know it is too small overall in terms of footprint. It is not designed to meet the current standards for an emergency department, and it doesn't offer the right environment for children, for anybody with a learning disability, for anybody in a mental health crisis. There are very clear standards for what an emergency department should offer for anybody who potentially has to need those services. And unfortunately, our sort of generic emergency department, which was right and appropriate 20 years ago, is no longer fit for purpose as to what an emergency department needs to look like today. Hence why everybody is taking it so seriously, and it has absolutely moved right up the priority list in terms of what we will see in terms of that capital investment moving forward. But we do recognise it. We do recognise it, and so busy, and ultimately, and this comes back to our our brilliant small island, this is a relatively small emergency department, but has to function as a major trauma centre because of the nature of our island and the uniqueness of our island and the types of injuries we see here. That ultimately mean we're not always able to fly an emergency patient straight off the island. Sometimes they have to come into the emergency department, and our department operates as a major trauma centre. Hence why we work really closely, which Oliver described, with the wider major trauma network in order to, as far as possible, meet as many standards as we can, whilst also recognising the absolute limitations that we still do have.
Good. Well, I look forward to reporting next year significant progress on creating a new environment for emergencies. I think it is a really key challenge, and other organisations I've worked in have just been through that. It's not without its financial and strategic challenges, but it's something that we are increasingly focused on prioritising those big infrastructure requirements. So thank you. So next question, how many patients are being treated in UK hospitals whose prognosis is terminal? Oliver, do you know that data?
Thanks, Wendy. Unfortunately, we don't collect that data. We don't collect it through our file and transfers team, and it's not data that is provided through the data feeds that we get from the NHS. It's not consistently measured as a metric by the NHS, so we don't know. However, our agreements that we have with all of our providers across the UK that are predominantly based within Liverpool, we would expect that anyone who is got a terminal diagnosis is managed within the same guidelines, clinical pathways, etc., as anyone who would be treated with the same diagnosis as the UK, which primarily is a decision, or the pathway of care for someone with a terminal prognosis is mainly driven by discussions between the family, the patient, and the multidisciplinary team around what the best options are for those individuals. We do have good links between Hospice Isle of Man, ourselves as Nobles, as well as other providers such as Clatterbridge and those other hospitals in the UK, to facilitate transfers to make sure that someone's palliative or their end-of-life care is as comfortable as possible and as commensurate with their wishes.
That's something that came up with the board, and the non-executives of the board, we've asked for a session of the board on end-of-life care so that we can hear what's available and actually look at what the assurance around that is. So again, that will be at a board in public, so it will be available to everyone in due course. Next question, why do you have to make a formal complaint to MCALS for action to be taken? Why not have a system like the DOI report a problem, which I found out about earlier? So Sheila, I think it's one for you.
Just to be clear, and obviously we're not clear, or else this question wouldn't be here. You do not. You do not have to go through MCALS to formally complain. What you can do, you can raise your concerns with anybody in the organisation. Why some people will recommend MCALS is because it's one single source of truth, so to speak. So you can use them MCALS to be able to get to other departments more quickly. Sometimes I'm hearing that doesn't work. In the next 3 or 4 days, and by the end of the week, we will be having up on our webpage the 8 senior matrons that have just been launched. And with that, we are also providing a portal for people to directly go into to be able to access those senior matrons. I cannot promise you a turnaround time on that yet, because we really haven't got there yet. But we are expecting our senior matrons to have opportunities to be looking at that portal at least 3 times a day. So if anybody wants to use it, it'll be up on the website soon, but you go through that portal, leave your name, leave your contact number, and somebody will get back to you. So apologies to anyone who's been told the only way you can make a complaint is through OFALs. That is certainly not the case.
That's really helpful. I think, again, having clinicians look at these complaints is really important, and getting back to people. So it'd be really good to see the data when we've got some of that, how good we are responding in that way. Really important. So the next question, there are two similar questions here about eye drops. So how is it allowed for an elderly patient to be sent home from ophthalmic outpatients late afternoon following a laser procedure with a community prescription for steroid treatment drops, but none of the community pharmacists keep in stock and take 2 days to order? Why is it not dispensed by the outpatient department for at least the first 48 hours of application with a community prescription for the rest of the period? And I think there was a second question very similar. So yes, I think from Mrs. Matthews, thank you. A similar question about it not being appropriate to send people who've just had an eye operation wandering around to a pharmacy to try and find the eye drops that they need. Why aren't they available to be handed out? Paula?
Well, the short answer is they are. It's just unfortunate that within the eye clinic, when you attended, they weren't given out for some reason. I know from experience, I had a very similar procedure a few weeks ago across basically a bilateral cataract operation, and I know that if I had been not given the eye drops, if I had been given the prescription with my eyes very light sensitive and being kind of guided to the car park by my dad kind of holding my hand, which is the case, to be handed the prescription and to be expected to find a pharmacy to dispense them is, I agree, completely inappropriate. I've spoken to our nurse consultant in ophthalmology today, who does reassure me that there are pre-labelled eye drops within the ophthalmology department that are available to be handed out. Clearly something has gone wrong in your case and you weren't given those, so he's going to make sure that process is reinforced with the staff present there to make sure that they are given out. So
absolutely unacceptable. So thank you for the two people that asked that question. And then a question for you, Sheila, around the matron roles, which probably you've gone from that as well. Why have you created matron roles that will not help improve the frontline nurse-patient ratio? If it is a management role, then it is not nursing.
Okay. So I think I said earlier about safe staffing and frontline, which is when we say that, we're talking about that frontline ratio, which I am very much close to, and we have seen significant improvement. In fairness, I would say, looking at the data over the last couple of years. Not only that, the additional roles that have been put into Manx care to support those nurses. So the role of the matron and the senior matrons here, as described before, if I can put it this way as an example, we want to raise the standards of care, and throughout these conversations that we've been having, I've seen some people in the audience listening intently and nodding. We don't get it right all of the time, and the impact of getting it wrong just once is significant. And the example there of not having eye drops after having surgery, that ruins outcomes. So we've got to raise standards. And if you look at the nursing profession, when a nurse qualifies or comes out with their degree, great, really successful, they're now a trained nurse. They're a trainee. They've come out of university and they've got to go through the experiences in order to be great nurses and in order to be promoted up that career pathway that I talked about. So let's get back to basics. So you're a trainee when you come out of university. So you're a junior staff nurse, then you may become a senior staff nurse, then you may become a junior sister or charge nurse, and so on. And then you become a matron across larger areas. And the matron role there is to make sure that everybody has the tools to do their job, because that's really important, or else the nurses can't do their job. to make sure they have the tools to do their job, and they tell them what those standards are in order to get really safe care, effective care, and a good patient experience and involvement. Above those matrons, then you have a line of senior matrons that I've talked about today. And the difference with the senior matrons is they set the standards. And so that's what now you set standards through clinical experience and clinical strong leadership. They're just not managerial roles. They are setting standards, they are visionary, they are looking at research, innovation. They're on the case of this artificial intelligence that is coming in. They're making sure that the people of the Isle of Man have got the right innovative kit, for example, to get the best we can, whether that be through diagnosis or through therapeutic caring. So I will keep saying to people, these are not dressed up managerial roles. The clinical leadership has been wanting for many years, and it's time to get that right. And the board absolutely buy into that and support it. So they're not managerial roles, but you have to have years of experience, knowledge and skill with different patients in different areas to be able to call yourself and get to the top there as a senior matron. And only when you've got those years of knowledge, skill and experience can you do that role and be that role model for the nurses who have just come out of university.
Thank you. So this is quite a long question. I'm just going to try and paraphrase this. Speaking on behalf of myself and many others on the Isle of Man who have experienced confirmed injuries following COVID-19 vaccination, as recognised by the Vaccine Damage Payment Scheme in our medical records, a major concern that we share at the time of vaccination were not provided with sufficient up-to-date information to give fully informed consent. And then it says, I'd like to ask, how did Manx Care justify continuing to administer the vaccines without updating consent forms and materials to reflect these emerging risks? And does the board accept that many may have given consent based on incomplete or outdated information? And what steps are being taken to review this issue, ensure transparency going forward and provide accountability and redress for those harmed? So, Oliver, do you want to start off with some of the stuff around vaccine? I think our public health colleagues here still. Thank you. So, Oliver, do you want to just start off with the sort of concept around particularly the consent and where we started with that?
So I think the history of the COVID vaccine programme predates Manx Care's establishment by a few months, probably about 6 months. The strategy of the island back then was to essentially completely replicate the UK's COVID-19 vaccination programme. Reasons behind that primarily around indemnity and supply and guaranteeing us a supply of the COVID vaccines, and also to ensure there was uniformity around PGDs, which is the document which allows nurses and other registered healthcare professionals to administer COVID vaccines without a prescription, which is given the scale of the programme was required and is a common theme across most vaccination programmes. That link with the UK programme has continued pretty much to the present day. We deliver the same range of COVID vaccination programmes as the UK, and indeed our supply is very much driven by the UK supply chain system. So we basically we deliver the COVID vaccines that are provided to us by the UK. Similarly, we provide the same, we replicate the same documentation, whether it's consent forms, as I said, PGDs, patient information, leaflets, etc. So we're very much tied to the UK COVID vaccination programme, and I guess as a wider strategic kind of point of view as an island, we subscribe to the Joint Committee on Vaccinations and Immunisations in terms of all of the programmes that we deliver. I guess from a JCVI point of view, if there is a decision by the JCVI to change the COVID vaccination programme, to change guidelines, to change the source of information, we will obviously follow that, but we are very much tied to the programme and the programmes that the JCVI deliver or recommend. From a governance point of view, and I might ask Ross to come in here because he's our consultant in public health. We're working together to review the governance arrangements for vaccinations and immunisations for the island. This is linked to some changes that are going to be coming along around how we deliver vaccinations as an organisation, and so I'm hoping that the reconstituted Vaccinations and Immunisations Committee, which is primarily attended by clinicians and other stakeholders, will help to increase that clinical buy-in around the vaccinations that we deliver. But we are keen in that process of reviewing that governance arrangements to have patient and service user input into that. So I don't know whether Ross wants to say anything or Chris.
Since we're here from Public Health, thank you.
Yeah, I'm well aware this is my rodeo, but just to sort of reiterate what Oliver says around the JCVI, there are a lot of very clever people looking at a lot of data from a lot of vaccine provision in England, and I think that, from what we see from that, any adverse effects associated with COVID vaccinations are extremely rare, and any risks are demonstrably significantly outweighed by the benefits, well-established benefits relating to prevention of severe illness, hospitalisation and death. So, just in relation to that question.
And my understanding is that the Council of Ministers has directed us to follow the JCVI instructions. So I think this is an issue for the Department and for Public Health in the Cabinet Office, I think you said, isn't it?
That's correct.
But thank you, really, really helpful, interesting question. How will Manx Care measure the success of the changes it's making to patient care? Chris, how do we measure success?
So there are lots of things that we count, and there are lots of things that we could count but maybe don't currently count. And I'd suggest then that one of those areas that we do count at the moment are things like patient concerns, contacts with MCARs, as Sheila's mentioned earlier, data in terms of mortality or adverse events, where we can benchmark our outcomes with other organisations. It's important that we count outcomes and talk about outcomes rather than just doing things, and that's the reason I mentioned that we count lots of things, but the things that are really important in terms of the patient safety initiatives are what difference it makes to actual outcomes for people. The things that we don't count quite as well as I referred to is some of what we call qualitative data. Having conversations with people and understanding perspectives that are sometimes a little bit difficult to put into a bar chart, but which nevertheless are still really important. So feedback from events like this, for example, and what in the UK we might be called the Aldi test, but I suppose over here we need to call it the Tesco test. How often you're stopped when you're going to do your shopping and you hear about the experiences of other people. All of this data is really important to capture, and I think if we keep a close eye on that, we'll see some of the improvements from the patient safety initiatives very quickly.
And just to support Chris, so Chris is brand new in, and we're straight away looking at a clinical and care strategy. And within that, we want to really look at what we call PROMs, which are patient-reported outcome measures. So they're used quite widely in other parts of the world. I think a really good example is, and though some people may have experienced this, if you go for a hip replacement or a knee replacement, you're asked what your life was like before you had it, and then what it was like in a year, and then they rewrite you again in 2 years. And it really, I think that in particular is a really good outcome measure. I had my knee replacement, I am now able to walk so many more miles, or I'm back walking up the hills, or I'm doing my cycling, and it's those sorts of things that we want to pinch with pride from other areas, and as Chris said, look at the research around what are the good patient-reported outcome measures. As Chris said, gone are the days where we're just focusing on the here and now, and our clinical and care strategy will very much focus on that. It's a bit of a so what, you know, I have my procedure and this is what it does. Another great one is of course cataract, if we make sure you get your eye drops.
May I come in there? You have all still missed the point. You've mentioned cataracts, you mentioned cataracts, that was just my point. It's all to do with who decides on the budget for drugs obtained from the pharmacy in the hospital versus those that are prescribed in the hospital, but you have to take that prescription outside to have it dispensed. You mentioned cataract. It wasn't a cataract because I had it for laser treatment. But the difference is that when you have a laser treatment, it is performed in outpatients, but you still have to sign a consent form. You take you give them the prescription, but please go to the pharmacy in Kirkmichael or wherever. Too late, she cried. Yes. If you're having a cataract op, you come out with your dressings and your eye drops. I'm talking about outpatients.
And
you still
we have no, we
and
just
no
established that we are
regulator.
going to have
It's clear.
these eye drops available for anyone that has a procedure, regardless of where it happens, because the relentless focus on the theatre procedure is, I mean, as we just put, it's something easy to measure, but the patient outcomes, your satisfaction, doesn't matter where you have a procedure, if you go home without the eye drops, that is a failure. And I will stand by that. I will hold this team to account. And in fact, I might tomorrow go and look for the box of eye drops in these places. I think this is a crucial point, and it's not something. I'm a doctor by background. It's not something you necessarily see from our side. So, hearing about it from the people we serve will change practice. So, I can promise you that I will go and look for these boxes of eye drops at some stage when I'm here, and we will hold the team to account, and we will have matrons crawling all over this, because you're absolutely right. It isn't about, and the answer to the question, it's about so what is going to make the individual's life easier and better and safer? Because some people won't bother to go and get those eye drops, and they will have further eye problems, and they'll come back, and that will be a massive failure. But it won't necessarily be counted as a failure until we look at the cause. That root cause analysis is now called. So it's a point well made. And I'll be going looking for eye drops. Really interesting question on slightly different tack here. Which areas are likely to start offering private services? Teresa, which one of you?
I think a lot of us need for private.
So we already provide quite a number of private services from Manx Care, primarily focused on diagnostics. So we provide a wide range of private radiology services. pathology. We provide a number of private services that exist around the Isle of Man with pathology services. We also undertake endoscopy privately here at the weekend. Also up in Ramsey, we operate a private plastic surgery service. The future of private services on the Isle of Man is, from our point of view, we're looking at developing or offering private surgery with, going back to cataracts, offering cataracts in the first instance. But what we need to do before we start any of that in terms of surgical procedures is making sure that our clinical governance and our quality systems are absolutely right. We know that through the presentations that both Chris and Sheila have that our quality of services is as high as you would expect in the UK, and we need to make sure that that same quality of service is delivered across our private services as well, and the same standard of governance, and just really making sure that those services are managed as tightly as possible. So that is the next stage. We've committed within the Timwall question that we will be opening private services in June. That is still our aim from a cataract point of view, but we are possibly going to be slightly delayed through our agreements with private medical insurance providers to be able to deliver that time frame, but that's something that we're still committed to deliver. But as I say, the priority for the next few weeks is to make sure that clinical governance and quality assurance systems are really, really well embedded before we go further.
Thank you.
I just want to sort of add, because I think it's been in Manx Care's mandate and a clear request of Manx Care since we started to be able to provide a private offer on the island and to provide as comprehensive a private offer as possible on the island. And we've had to be quite cautious in the approach to that, because it's very important that whatever we offer in that private space does not in any way detract from the capacity that we have available for the NHS. So it always has to be additional capacity over and above what we can offer to the NHS patients. And that is where we have had to take a really cautious approach, because I don't want to open up the private unit and staff that ward with nurses who have transferred across and we have to close an NHS ward. It has to be true additionality in our system in order to protect the NHS capacity that we have available and within the budget we have available, and the private offering we have to the island's population is true additional activity and choice. So it's not instead of, it's as well as. And I think that's really important that everyone understands that. And that is why we've taken quite a cautious approach. It is about getting the quality and the governance right. It is about making sure that that capacity which is used for private does not denude and take anything away from the NHS service that we provide and that we're committed to providing.
Is it fair to say that some of the big insurers have issues with the volume of work here and their cover offer?
Yeah. Yeah, absolutely.
Which must be disappointing for some individuals. So it isn't always something in our control whether the insurers will fund.
Yeah.
So I'm going to go to the final question now. Anyone else that's submitted a question we will answer in writing. Final question, I think is one for you, Teresa. What do you think the biggest challenges and opportunities are this coming year for Manx Care?
I think the biggest opportunity, and I think this opportunity has probably been there throughout. We are small, we are perfectly formed and we have everything around health and social care under Manx Care. And that presents a fantastic opportunity to try and look at where we can integrate, make the best use of our workforce. What we've heard loud and clear from the discussions we've had, and we want to do more of this and we genuinely want your feedback, is we really want to focus on getting those services which are outside of the hospital in a much stronger position. Now, this isn't denuding the hospital's capacity or any services in the hospital, but what we are saying is we want to really deliver as much care to people in their local communities as possible and get the access better, more timely. We want to put more GP appointments into the system, more primary care practitioner appointments into the system, those first contact practitioners in physiotherapy, in mental health, and dental access. We've heard that loud and clear. And we are absolutely now focused on a number of initiatives which will hopefully, when we speak to you this time next year, we will be able to demonstrate the improvements that we have made. So I still think that is such a huge opportunity for the island as we expand and develop those services in the out-of-hospital setting. The challenge, and it's not necessarily the money, the challenge is being able to do a lot of this at the pace that we really want to do it at in order to be able to deliver those tangible benefits. Because sometimes we need to double run some of those. So it's really hard to switch one thing off and one thing on. You just can't do that. You have to double run and you have to do the transition. I'm very conscious that over the last 4 years, a lot of the improvements that we have made and that we've talked about won't necessarily be obviously visible to those people using our services. And that's something we are acutely aware of, because we would have liked to have demonstrated much more progress. But we have had to get the quality assurance systems right. We have had to reduce the gap in our workforce to be able to assure what we have is safe, sustainable, high quality. And I genuinely believe we can and have made really improvements in that. My desire for the next 12 months is to have much more conversations with the public and those that use our services, so we can, as we go through those transitions and those changes and we describe and we look at what services need to look like in the future. And I'm not just talking about next year, I'm talking about what does 10 years time look like. Because we need to think about that. We need to stand ourselves in the future and know what the population of the island looks like and the types of services the island is going to need. And I genuinely want us as Manx Care to sort of step out of the internally focused machine we've been in and really look up and out. And I genuinely believe that we have reached the point now where we can do more of that and really make a difference and hear what the population wants. So I see that as an opportunity, and genuinely this is not about the money, because I think fundamentally if we can get the service delivery models right and co-produced and we hear the public voice, we can make those changes which mean the services we design and deliver for the island are right for the population we serve.
Thank you. Really good note to finish on. Thank you very much, Teresa. So thank you to the exec team, but mostly thank you to you for your questions. Please write to us if there's any follow-ups that you want. We will endeavour to answer them. And thank you to those that came last year and come to the boards and public. It's really important that we hear and see you. I really like this venue. I think the air conditioning's gone off, so sorry it's a bit hot towards the end of the evening, but thank you very much. I look forward to seeing as many of you as possible, as many events over the next year as we roll them out.